in typical street medicine fashion. At least this is kind of the way it is here in Los Angeles, where things are kind of spread out. We were out rounding in one area of the city, kind of close to downtown, and then or over in Hollywood, and then trying to kind of scramble and make it back here. So sorry for the late, a little bit turbulent start, but we can go ahead and get into it. So I'm Dr. Shane Collins. I'm a psychiatrist with USC Street Medicine.
Good afternoon, everybody. My name is Lisette Carmona. I'm the LCSW and social work manager for USC Street Medicine. We're also joined by one of our newer clinical social workers, Haiti, who's also to the side of me.
Off screen,
Yes.
but
Yes.
here in supportive presence. So we're invited to give this talk today to discuss psychiatry in the streets and just mental health care in general for people experiencing homelessness. Fortunately, I tried to make this talk kind of short and sweet in terms of the content presentation to give time for questions at the end and hopefully just a nice robust discussion. I think we should still have time for that, even though we're getting a little bit of a late start. We do not have any disclosures of conflicts of interest we need to report. So things we hope to cover in this talk. So, just I guess there's a question I have for all of you starting off. I don't know if people can chime in, but I wasn't sure, this student group, are you all like mostly medical students, or is it sort of a mix of undergraduate students or like therapists? And you have an idea of kind of what the makeup is?
I would say a mix, but we do have a lot of like majority medical students.
Okay. And I assume there's some familiarity with street medicine if you're
Yes.
part of this group. But I don't want to take that for granted. So just going to explain kind of what street psychiatry is and talk mostly about why there's a need for street psychiatry and street mental health care in general. I should say that the name of this talk is street psychiatry. And I want to acknowledge that that's maybe not the most inclusive term. Joined here by two phenomenal two clinical social workers. One's licensed, one is on her way to becoming licensed. And so just acknowledging that mental health care is very much a team sport. It's not just the MD psychiatrist coming in and doing all the work, but psychiatry in general, just kind of referring to that branch of medicine that deals with mental health. We're going to talk about our model for how we integrate mental health care into medical care here at USC Street Medicine, and then share sort of things that we've learned firsthand, insights from working with people, providing mental health care with people experiencing homelessness on the streets of Los Angeles. Okay, and first we're just going to do a quick sort of orientation to USC Street Medicine in general, and I'm going to pass the mic over to my colleague. Or no, I'm covering
No.
this part. Never mind. I'm going to stick with this. All right. So just talking about the location that we practice in. So we are here in beautiful Los Angeles, California. It's a bit of a unique place for many reasons, but particularly in terms of the population that we serve, which is people experiencing unsheltered homelessness. So this map shows estimates of people experiencing homelessness by state. And you can see here the two largest states in terms of population, people experiencing homelessness, is California and New York. So keeping that in mind, right? Like 187,000 California, 158,000 New York, both really huge numbers. But then if you look at this slide, it's really interesting. So this is looking at the percentage of folks who are unsheltered in these states. You can see 66% California, 4% New York. So real vast difference there. In California, Los Angeles consists of 40, or California, I'm sorry, has 49% of the entire country's unsheltered homeless population. And in Los Angeles County, we have 47,450 people, is the most recent estimate, who are experiencing unsheltered homelessness. For you, those of you who aren't familiar with these terms of sort of unsheltered, the distinction between unsheltered and sheltered homelessness, Sheltered homelessness would refer to someone who doesn't have a permanent, stable place to live and sleep. So this might be people who are staying in a shelter, congregate living situation, maybe doubled up, staying with family members or couch surfing, but they don't have like a permanent place to live. Unsheltered homelessness refers to people who are living in encampments, single tent on the sidewalk, in parks, under bridges, in cars, really anywhere that was not meant for human habitation. And again, just driving home the point of like why Los Angeles and New York City have similar overall size populations of people experiencing homelessness. Los Angeles has a much higher portion of people who are experiencing unsheltered homelessness. And this matters for many reasons, not the least of which is that people experiencing unsheltered homelessness have 3 times the rate of death of people experiencing sheltered homelessness, who also die at a higher rate than people who are permanently housed. Okay.
Okay. Good afternoon, everybody, again. So this is just a little bit of some information on our coverage area. We currently have 5 teams that operate within the city limits of Los Angeles, with the exception of Skid Row. If you're familiar with the area, there are quite a bit of services in Skid Row. So we are not funded to cover that area. But amongst all 5 of these teams, we do have specialized teams within those teams, which includes myself and Dr. Collins and Haiti, who make up the core mental health team. And then we have like a HIV specialty care team, an OB team. We also provide gender affirming care. And even within these teams, wherever our patients move within these areas, we still continue to cover them. So if we sign them up in these specific areas, but they did move to Skid Row or they went inside shelter, whatever the case, we continue to see those patients. So just to give you like a rough estimate, our team sees on some average months 13 to 1500 visits. Our core mental health team, again, which is the 3 of us, covers every single one of these teams. This is just an example of one of our trucks. We are not a mobile clinic. Again, we are backpack medicine. We are going patient to patient. So our teams are jumping into these trucks every morning to go out and see patients. And this is just an example, again, just driving home that we are backpack medicine. We are going patient to patient. We are not, all of our care is patient centered. So when we're here, it's because our patients want us to be here and they are open to services both medically and for a mental health care. This me?
I think this is neat. Yeah. All right. So as promised, what is street psychiatry? Well, there's no like official definition of what street psychiatry is. And as a fairly new field of psychiatry, I think it's somewhat still being defined. I put together this definition kind of borrowing actually from the Street Medicine Institute's definition of street medicine in some of our own terminology that we use here at USC Street Medicine. So seeing street medicine as a model of mental health treatment delivery that, well, minimize this other window, that brings services directly to people experiencing unsheltered homelessness in their own environment. Again, driving home that point that we're not, I think mobile clinics have a really important role in, again, like fairly qualified health centers, so sort of serving similar population. But what's distinct about this is that we're, again, going out to the patients and seeing them in the setting in which they live. Why is there even a need for street psychiatry? As many of you probably know, there's a high prevalence of mental health disorders among people experiencing homelessness. The sort of estimates put this somewhere around 67% of people experiencing homelessness have some form of a mental health disorder. This is compared to the general population, which is much lower at 13 to 15%. You can see some of the disorders. This is not a complete list, but just some of the disorders that are more prevalent among people experiencing homelessness. Very common disorders like major depression, psychotic disorders, which could include schizophrenia, schizoaffective disorder. They see bipolar disorder. So again, seeing, that there's a much higher prevalence of many of these disorders among people experiencing homelessness. This is a graph that's showing some of the the top 5 causes of death in Los Angeles among people experiencing homelessness. And you can see the red line clearly is much higher than all the other ones, and that has to do with drug overdose deaths, which have largely been guided by fentanyl-related overdose deaths, commonly mixed with methamphetamine use. You can see, fortunately, the line is starting to decline here at the end. This graph leaves off at 2023. Also fortunate that this trend has continued. We've seen a decline here. The reason I bring this up is because in addition to doing psychiatry, I'm an addiction medicine doctor, and certainly in the streets, I guess this is true elsewhere also, but it's really evident in the streets that mental health and substance use are very much linked. So, even if we're not the ones that are directly prescribing medication for opioid use disorder, often that's already addressed by our primary medical teams. A lot of the work that we're doing is getting at some of the underlying reasons that people are using substances to cope or for other reasons, and trying to treat their mental health conditions with their substance use disorders as well. I included a slide in here because I wanted to drive home this point. Whenever I'm talking about mental illness and homelessness, I'm always a little bit concerned that I'm going to sort of misrepresent this and reinforce this popular conception that really is a myth, that mental illness would be the reason that there's high rates of homelessness in some of our nation's cities. This has been disproven, and there's a book that came out a few years ago, included here, Homelessness is a Housing Problem. These are some researchers up at University of Washington that I think laid out really the best evidence, really thoroughly disproving this myth of mental illness being the primary driver of homelessness in our country. Really showing that, while at an individual level, mental illness and substance use disorder can be a risk factor for experiencing homelessness, the disparities in regional populations of homelessness and the growth that we've seen in recent decades is really driven by structural factors. And a lot of it has to do with lack of affordable housing, which is certainly what we see here in Los Angeles, being a very expensive city. To further drive home this point, they give the example in the book of Chicago and San Francisco. And so showing that these are two cities that have pretty similar rates of mental illness, and the same goes for substance use disorders, but have drastically different prevalence of homelessness. So you can see in Chicago, it's about 200 people per 100,000. And then you see in San Francisco, it's about 1,000 people per 100K. Obviously, different size cities. So we're going on per capita rates. And then you look at the housing price. And this is something that astonishes me as being someone who's lived in California for quite some time and gotten maybe a little bit numb to the high cost of housing. The median home price in Chicago is $334,000. Where here, it's pretty close to 1.5 million in San Francisco. And I think the same holds true for most cities, coastal cities on the West Coast. So really, again, showing that it's housing. And yeah, to drive this point home even further, if you haven't got it by now, yeah, this is really what we need. And at the same time, we acknowledge that here in Los Angeles, a lot of our people who are seeing on the streets are chronically experiencing homelessness. So they've been out there for a long time. And even if mental health or substance use was not a primary reason for experiencing homelessness, for starting to experience it, sometimes we say that it's like, well, if you didn't have mental health problems before you were living on the streets, you probably do now. And that's just because it's an incredibly difficult environment to live in, and often it is characterized by traumatic experiences. So we're not waiting essentially for people to get housed before going out and providing care that can help improve their functioning and reduce their suffering. Why do we go out to patients? Well, again, this may be obvious to many of you who are familiar with street medicine, but people experiencing unsheltered homelessness face myriad barriers to engaging with mental health care, ranging from cost, lack of insurance, of course, transportation, especially in a city like Los Angeles, which is pretty spread out, not having identification, which is a big thing. It's often the case that our patients lose their belongings, are stolen, or the city comes through and does so-called sweeps, which are really just forced displacements, and their items are disposed of. Healthcare system is really complex and difficult to navigate for most people, even if you have quite a bit of resources and privilege. It's difficulty maintaining schedules when you're living out on the streets, having to take care of competing needs or stressors. Do I go ahead and make sure that I have a place to stay tonight that's safe? Do I make sure that I have food to eat, or do I go and get my medication refilled? Right? Having to make those sort of decisions. Not having a secure space to store your belongings. This kind of goes both ways. Sometimes it's like I don't have a place to keep my medications safely. But it also can be I can't go to the doctor's appointment, and I can't go to the pharmacy to pick up my medication, because if I do, I have to leave all my things behind, any clothing that I have, any resources, pets, really meaningful belongings, that are there.
Or even
Pictures, stuff
having a
like that.
phone to call to make these appointments.
Not having a phone, oh, I left that one out. That's a big one. Yeah. Sometimes it is the case where it's untreated mental illness or a substance use disorder addiction that gets in the way. And then a huge, huge one, and I can't overstate this enough, is stigma and discrimination and mistreatment within the healthcare system and the mental health care system itself. There's a lot of distrust, a lot of fear, a lot of anticipation of being treated poorly yet again when someone goes to seek mental health care. I'm in a fortunate position here where we'll talk more about our model of integrating mental health care at USC Street Medicine. But the patients I'm seeing have all been seen and developed rapport with the rest of the team, generally the primary medical team. So it's very often the case that patients are a little bit unsure if they want to see a psychiatrist, and that's often based on negative experiences they've had with either psychiatry or the mental health care system, generally speaking. Oftentimes it's been in like a brief encounter in an emergency department or involuntary hospitalization. They felt like they were coerced to take medication in some way, or just generally stigmatized and treated poorly. So a lot of the work that we're doing is actually repairing some of that institutional distrust that exists there. And so acknowledging all these immense structural barriers that people experiencing homelessness face, conventionally, the expectation is that, hey, patient, if you're able to overcome all these things, maybe we'll help you. Maybe we can get you a phone. Maybe we can get, a bus voucher or something like that. But it's really on you to overcome all these structural impediments. And then if you come here, hey, we're here. We'll help you out. We can give you some medication. Maybe if you have insurance, maybe not therapy, because, that's usually not going to be available. But, if you make it here, we're here. We just know that does not work for so many people. And so instead we say, well, hey, we have resources. We have privilege and prestige that we can leverage. Why don't we be the ones to overcome all these barriers? We go out to patients and proactively engage with them. And that's exactly what we do in street psychiatry. In terms of research, a sort of evidence base for street psychiatry, well, this is very much evolving and new, so there's not like expansive literature on this, but some of the early evidence that's been done in street psychiatry shows in fact it is effective in reducing psychiatric symptoms. There's reductions associated with or associated reductions in days of homelessness, increased engagement and connecting to outpatient psychiatry and substance disorder treatment, and then lower rates of hospital admission for people experiencing severe mental illness. Another thing I wanted to point out here is health equity, just kind of looking at this from a health equity lens. And, I'm a psychiatrist, but, when I look at my field sometimes, I'm like, what is going on in psychiatry? Mm-hmm. Psychiatrists really stand out from other medical specialties. If you look at the graph on the left, that is not accidentally coded in New York Knicks colors, because I'm kind of hyped on their performance right now. I'm originally from New York. You'll see that 40% of psychiatrists cash only, right? It's not even a matter of like, hey, we don't take Medicaid. Like, we just don't take insurance. We're just doing cash practice out there, right? And there's various reasons for that. But the issue is the folks who, we know that as socioeconomic status is lower, there's higher rates of need for mental health care, and that has a lot to do with the stress of living in poverty. So the folks that need psychiatric care are often the least likely to get it in this country. The same holds true for psychotherapy. Folks who are at a higher level of socioeconomic status have very fancy insurance and ability to pay out of cash, way more likely to get psychotherapy than someone who has Medicaid or is uninsured. So when I was sort of bright-eyed, bushy-tailed medical student, I was really influenced. I was introduced to the works of Dr. Paul Farmer. Some of you may be familiar with. He's passed away a few years ago, but just really amazing physician and medical anthropologist and really humanitarian. And he talks about in some of his writings this idea of having a preferential option for the poor. And this is a concept that he borrows and adapts to medicine from liberation theology, which was a movement in the Jesuit church in the 20th century to say, hey, you know what? Really what we should be doing as a church is we should be prioritizing the poor. This is where like the suffering and the injustices exist, and that's what we should be spending our time on. And so over on the left, you see Spanish Jesuit priest, Father Pedro Arrupe, who really coined this term of a preferential option for the poor. This is a picture that was taken in Quito, Ecuador. And what's going on here is you see the boy that's sitting on the chair. He was a shoeshine boy that was living in poverty, and he came up to this very famous priest from Spain and said, you know, could I have the honor of shining your shoes? And the priest said, sure, why not? And so after the shoe shine, the priest said, well, now it's my turn. And he went back and, got down on his hands and knees and shined the boy's shoes. It was very reciprocal in that way. The picture you see here of Dr. Paul Farmer, a lot of his work was in Haiti, and this is in a clinic that he founded in Haiti, and he's caring for a patient. The picture was taken, I think in 2003, I want to say, who was essentially dying from HIV and tuberculosis. And HIV at that time in Haiti had pretty much been abandoned. It was saying, hey, this is too expensive to try to treat HIV in this very poor country. There's so many issues that are here. They don't really even have a healthcare infrastructure. And he challenged that idea and said, you know what, actually, these are the places we should be putting all of our resources in as just a matter of social justice and health equity. And I very much believe that, that's what drives and should drive street psychiatry. And I take a lot of pride in that. And we'll talk again more about how we do our work here. But I truly believe that what we're offering to our patients, it's not just a good enough model of psychiatry. In many cases, I think it's actually really exceptional and better than the general standard of care that most people are experiencing when they access mental health care in this country. And this is a letter I recently presented a very different audience, also students though. I went and I gave a career day talk on being a street psychiatrist at my son's middle school. He's in 6th grade. And after the talk, I got a whole bunch of thank you letters, which to be fair, I think the students had to write these, but they got it. There was a lot of students that just wrote these really beautiful things. And one of the students wrote this: some people help the people who could afford it. Others help the people who need it the most. It's really capturing that idea. Okay, I'm going to pass it back over to my colleague Lisette to talk about how we do mental health care at USC Street Medicine.
So this is just kind of like a quick snapshot of the evolution of mental health within USC Street Medicine. Prior to my arrival here in January of 2023, the medical providers were doing like kind of more general mental health assessments, giving out psych meds, but also utilizing external supports. And then I showed up. And again, there's kind of this misconception of what a master's level social worker is able to do. We don't just take away babies and hand out bus passes in a hospital. We are fully qualified to assess, diagnose mental health. We are able to begin treatment by way of psychotherapy, not meds. And so as I got here and kind of had that influence on the teams and the provider and started sharing that information, like, hey, we don't have to send this out. I can do this, right? So I started doing kind of real-time crisis intervention, real-time therapy appointments, and that kind of led to, I'm sorry. And then that same year, at the end of the year, we had our first street psychiatrist. And so we were kind of still figuring out how was that going to fit. But from the beginning, myself and psychiatry kind of teamed up as the core mental health team. And they were also providing clinical supervision for myself as the clinical social worker. And then in 2024, Dr. Collins showed up and completely, like mental health care here kind of completely evolved into something kind of different and, more consistent consults. And we were um, cycling through different teams every week, and we started holding monthly case conferences and kind of this continuous education of our current teams for everybody on the team, not just medical providers, our community health workers, our medical assistants, our nurses, because they have this higher touch with our patients and just they needed to, we wanted to educate them with the awareness that just these consistent conversations with our patients who might be anxious, who might be depressed, and how important that is and how much that is a benefit to improving mental health over time as well, not just psych meds and not just a therapy appointment. Oh, yes. Earlier this year, we welcomed Haiti. We finally got some additional help. So she is also a clinical social worker for our CD1 team.
I added that animation in the last minute, so I didn't know that.
And just for like your information again, because there is often misconceptions about mine and Hades field. So just to give you a kind of snapshot, when we say clinical social workers, this is the piece that we're talking about. We have master's degrees. We have spent thousands of hours in internships and learning to diagnose and learning different therapeutic modalities and learning how to provide substance use support and learning about crisis intervention and how to assess for suicidality. But we're also doing this in real time. We're also consulting with several of our medical providers when somebody is disclosing a sexual assault or domestic violence and they're getting ready to leave. Now, we also host MSW interns here and hopefully influence the new workforce of how this work can be done. And then social work here also does kind of advocacy stuff, referrals, all of your kind of basic case management stuff. And this is what our collaborative care model looks like for us. In the center, you'll see our patient and then the primary medical team, which has the highest touch with the patient because they're seeing them weekly, sometimes multiple times a week, sometimes every other week. It's all determined by the patient's need and how much they'll see us. Clinical social work is to your left. We're in constant communication with our team. We are housed in literally the same office. We do not practice in silos. We really are MDT. We are like yelling at each other in the same office when a patient needs something. And then we have Dr. Collins, our street psychiatrist, who may not have consistent contact with the patient because he is here 1 day a week and he rotates through each team every week. We, as the medical team and as the mental health care team, are in constant communication with him and bugging him for consult questions and patient questions through Teams, through phone calls and text messages. So this is kind of the way that we do things. We are lucky enough, like I said, to be housed in the same place where we can have this really truly collaborative care model to give the best care to our patients. And I do want to say, like everything, including the mental health piece, is patient driven. So the medical team is asking our patients and letting them know, like, hey, we have this service, but it's completely up to you if you want to participate. This is how our patients get referred to what Dr. Collins and I refer to as Psych Day. Our primary medical teams these are their patients. They will email us. Dr. Collins sends out an email the week prior to whatever team is coming up next. We are given some information about those patients. As far as clinical social work is concerned, we may have already met with these patients. We may have already started therapy or met them during a crisis, but there is this ongoing relationship with our medical team. And then the medical providers or RNs are kind of letting mental health care team know, which is myself, Haiti, and Dr. Collins, of what the need and why the reason for the psychiatry consult. And then we are scheduling those patients and going to see them on psych day. And then we're coming back at the end of the day. Dr. Collins is doing his consult. Haiti and I are discussing with Dr. Collins whether these are people we are going to participate or put in our therapy rotation, and then we're bringing all of that information back to our providers at the end of the day. And then, the follow-up for any meds or anything like that is then taken back on by the medical team. And this is just kind of a slide that was put together to show the benefits of this collaborative model. Of course, there's an increase in access and kind of this, I'm drawing a blank right now, but the increased access to care, we're reducing the barriers of having to be on wait lists for mental health appointments. We are reducing the barriers and the time that it takes for the communication between psychiatry and the medical team because we are here together, which increases our ability to see more patients weekly because we're not waiting for these things to kind of be addressed as far as like medications and stuff like that. We are also reducing the stigma. The medical team does an amazing job of building relationships. So by the time that we walk in, this is already built in. There's already a trust that that medical team has built with us. The quality of care is much higher. We have seen improved outcomes. We Dr. Palms can speak to this as well. We consistently hear, oh, I won't talk to psychiatrists, but I'll talk to you. Or I don't like therapists, but I'm going to talk to you because of these relationships that have been built, but because also there's this everything we do is kind of patient driven. If they don't want to talk to us and they are not forced to talk to us or to participate in mental health care, they can continue on with the medical care and we hope that consistent conversations over time and the trust being built will bring us kind of back into the picture. And again, the efficiency, there is more efficient care because we are here in the same office yelling at each other about kind of what's going on and we're triaging things pretty quickly in real time. There's not a need to wait for anything. Everything is streamlined. Communication, we're texting, we are calling, we are communicating via Teams. And again, just this real-time care coordination, I think, is what sets us apart and what makes things move a lot quicker for our patients, which increases kind of the quality of care and their access to care. There's not really kind of this time that they have to wait where they can change their mind about accessing mental health care. And we are prioritizing equity. We're giving amazing mental health care. We are giving them direct access to their meds, to psychotherapy. We are bringing it to them because there's an understanding of how difficult it is to access mental health care, even down to like injections and medications. If our patients are unable to get to a pharmacy, we're not just calling in a medication and expecting them to figure out how they're going to get it. It's just not going to be helpful. Many of our patients often are treated differently, especially our ADHD patients who are trying to get their Vyvanse often run into issues at the pharmacy. So if our patients are unable to do that, then we are picking up meds or we're having them delivered to our office and we are bringing those directly to patients. And if our patients are unable to maintain kind of their medication schedule over a long period of time, then we're coming and filling up pill boxes for the week to make sure that they're okay for, the time being. Anything else you want to add to that part?
No, I mean, well, yeah, I guess yes. No, but yes. I think the collaborative care model, one of the reasons I want to highlight this here, it's partly we do this because we need to, because there's, psychiatry is a limited resource. I get my funding through the city of Los Angeles, and currently it is just for 1 day a week. So it's a way that we can really kind of stretch out this resource. So I think it is a good model to consider if you're going to be working within a medical team and if you have limited access to a psychiatrist or psychiatric nurse practitioner or someone with specialized knowledge about prescribing of psychiatric medication and mental health in general. And then it's also safer. Like there's a safety element of it where traditionally, mental health in our healthcare system and physical health have been completely compartmentalized, right? And so it's like you go one place for your physical stuff, and if you're too mental illness is like kind of part of it, like, oh no, you go over to the mental health clinic, right? And so there's not a lot of communication in most systems between those two things. We're here, I will go see a patient that the primary medical team already knows. I will do my assessment, and then at the end of the day, I come back and I talk with the primary team and I explain to them why I'm thinking what I'm thinking diagnostically, what I'm recommending in terms of treatment, which may or may not include medication. And then we're considering collaboratively how this affects the patient's care holistically. So thinking about both the mental and the physical health of our patients, making sure like that there's not going to be any medication interactions, that what I'm recommending in terms of psychiatric medication, for example, is not some way going to negatively affect their health. There's not some contraindication that's there. And all this is happening like on the spot in real time. So again, really not just your sort of good enough model of mental health, but I think really exceptional high level mental health care.
And I think we try to kind of extend this out to people outside of USC Street Medicine when our patients are in the hospital, when they're on psych holds. We do our best to contact them to let them know that they have been working and receiving mental health care via USC Street Medicine, especially if there's any medications that the patients have been injected with or anything like that to avoid kind of any overlap in medication and just so that we can have that continuous care and know what the patient has been undergoing when they're released because they are almost always released back to the street and oftentimes don't have discharge paperwork, don't know what was happening in that facility. So Dr. Collins and I and our medical providers do our best to kind of continue this collaborative care or attempt to collaborate with external providers and facilities as well.
Just kind of checking time. I want to make sure there's times for questions. I'll just kind of move through this quickly. So I'd say, we get consults for different reasons. Again, the primary team are really triaging this. In general, I'm usually seeing the patients that are either the highest acuity in terms of their mental illness, or just complex diagnostically, which is very often the case here because there's a lot of confounding variables at play. And, I might get a consult for psychosis, and it's hard to tell because it's like, well, this patient may have an underlying psychotic disorder. They're also using methamphetamine in order to stay up at night so that they're not victimized and function during the daytime. And that maybe is looking a little bit like mania at times. And unfortunately, trauma is pretty ubiquitous on our streets. So maybe that's part of the picture here. And then there's things like, behaviors that would typically be pathologized in the DSM-5, things like hypervigilance, right? Or the sort of hyperarousal. We typically think about those as symptoms of PTSD. Those often are just rational responses to life on the streets and actually quite adaptive in that environmental context. We see a wide variety of psychiatric diagnoses. When I first came here, I sort of assumed that this was going to be all what we call severe mental illness. So a lot of psychotic disorders, bipolar disorder. And sure, we definitely see that, but really seeing a pretty wide breadth of psychiatric pathology, which I think speaks to the fact that a lot of the patients we're seeing have lived on the streets for quite a long amount of time, sometimes years, sometimes even decades. And so our population that we're seeing of people experiencing unsheltered homelessness starts to, in some ways, kind of mimic what we're seeing in the general population in terms of people having just all sorts of different mental health problems. Trauma, again, just to highlight this, is really ubiquitous and often, if not a part of our patients' experience, their narrative in terms of childhood trauma or trauma earlier in life. Unfortunately, it's often part of the story of living on the streets and experiencing homelessness. Some just clinical considerations, things that sort of stand out and maybe a little bit different about doing psychiatry in this setting. Well, one, again, maybe this is obvious, this is an outreach model, right? So we're not sort of asking the patient to come to us and sort of opt in this way. We're going out proactively. Again, it's a primary team that's initially kind of offering mental health care. And then, considerations of privacy and confidentiality, we do our best in this regard. But as you can see in the picture here, I'm sitting on a bucket, talking to a patient sitting on the tailgate of our truck on a kind of little rainy day in Los Angeles. But, we're out in public, we're out in the open. So the way that we navigate this is really going off of the patient's level of comfort. And so we often ask them, is here a good place? Are you comfortable with having this chat here? Would you like to kind of go around the corner? What would be best for you? Diagnostic uncertainty is often the case. It's rare that we have the ability to get collateral information from like family members to get a more in-depth history, or we do our best to try to get medical records. Often those aren't not available, so it can be hard to say definitively whether this person has schizophrenia or this is the psychotic symptoms they're showing are more attributable to other factors. We have to make certain considerations for medications. So in general, trying to avoid medications that are sedating because that's quite dangerous on the streets. We, when possible, will offer long-acting injectable medications because it can be really difficult to adhere to a daily oral medication on the streets. And then there's all sorts of ethical considerations that come up. So it's been interesting for me as a psychiatrist. We're also, as a profession, I'd say, probably more boundaried, informal in our boundaries than a lot of other medical specialties, often for good reason, given the sort of emotional, personal qualities of the work that we do. But there's things like it'd be rare for me to treat a patient and then also the patient's partners to treat someone like outside of the context of like couples therapy or family therapy, right? To have two separate patients, usually that's a little too close together. That happens not infrequently on the streets, and that's sort of just because if it's not me, then probably this person is not going to get mental health treatment, they're not going to get psychiatric treatment, and they're suffering pretty gravely. So I could talk more about this kind of stuff if people are interested in the question section, but let me see what else we had. I just want to ending with a quote. So this is from one of our patients who said this really beautifully. She says, "I wish more psychiatrists and therapists took the time to sit with us and listen to us like you guys do. Everyone is usually judgmental of homeless people. They think we're all just mental patients, but you guys just listen and treat us like we matter. I would have given up by now." And that's really it's so poignant and such an important part of what we do is really just treating our patients with dignity, being authentic with them, right? So we've kind of learned this. I've had patients say it multiple times of like, hey, I'm willing to trust you because you're willing to trust me. So this is there's a mutual respect and really treating patients all the time with dignity and unconditional positive regard and consistency in what we do and sort of making sure that we're showing up consistently and that if we promise something, we're delivering on that. This is not the patient's real name, by the way. Okay. I'll open up to questions. I want to say I include this piece of artwork. I've been including it in a lot of presentation I do. This is from one of our patients, an older man who was housed, actually, had been experiencing homelessness in the streets for a long time. And he was housed, but continuing to struggle with depression. And we had a big, long talk about medications. And he actually was open to me prescribing medications once, but I came up for a follow-up visit. And he was like, I got to tell you, he's like, I didn't take them. I don't want the medications. And I was like, that's okay. Like, I'm glad you could tell me that. And so we started talking about other ways of, coping with depression. He had a lot of loss in his life, a lot of difficult things he's experienced. And he mentioned, well, kind of like drawing. And I was like, oh, cool. Can I see one of your drawings? And he, pointed towards the fridge over here. And he had this drawing, which just makes me like smile every time I look at it, which is like, it's just really interesting. Like he's suffering from depression kind of down, but had these does these cool drawings, these bright drawings, these like happy, smiling sunshines and really cool. The other thing I didn't notice this till after I took this picture, I asked for his permission to take this picture, is you see up in the corner next to the New Mexico alien, there's some names there, right? See Ellipsa, Mario, and Jose. Those are all members of our team. So he had like our team's numbers on his fridge, which I think is pretty cool too. So, okay, I will stop talking and open it up to questions. Oh, we should probably stop sharing our screen, I think.
Because my thing doesn't work very good.
Okay. How do we stop sharing here? Oh, wait, are we still sharing?
Yeah, I think so.
Maybe close. You need to do it. Let's do it. Oh, I know it's still there. It's still there.
Well, I think I just have to go look at it.
Yeah.
No, let's just remove.
Click on the share.
Yeah.
And then
it's like asking me to share.
Yeah. Is it still sharing? Oh, yes, still sharing on our end.
It's still sharing.
Yeah, it's still sharing. We're all.
Is there a button at the bottom that says stop share?
No, it only allows us to share.
Oh.
Can you kick us out of sharing?
Oh, wait, maybe if you go to top.
Oh, yeah.
It was just off screen.
Okay.
That worked.
Perfect. Okay. Oh, I think he's put our contact information. Yeah, please feel free to follow up with us, get in touch if you guys have any questions or want to talk afterwards. I think you can see the chat. Oh, we have a social work student in here. That's so awesome. We love social workers. Cool. Okay. Any questions?
Hi. Thank you so much for your talk. It was really insightful. I'm actually interested in doing psychiatry, specifically street medicine. But I had a quick question about how to, keep longevity of care, especially when there's encampment sweeps and people are moving around. How do you establish, continuity of care with individuals if they lack a cell phone and they have to be forced to move and things like that?
I think a lot of the credit for that is related to the relationship built by the medical teams. So initially, when somebody signs up with us, part of the intake is asking, "Hey, if you're not here, where are the other areas that you go to?" So we are immediately asking those questions. We are getting cell phone numbers. We are asking for, like, we are giving our contact information because I have never not seen somebody try to get a hold of us because of the relationships that are built by the medical teams already. And so when people need something from us or they want to see us or they know, we also have kind of consistent days that the medical teams show up. So they know that, okay, even if I move, if I'm in this particular day, I know that my medical team is here that day. But also patients will use other people's phones to get a hold of us to tell us. And usually, again, because of relationships that we've built with external partners, like the city and different consult districts, we are kind of informed ahead of time of some of the encampment sweeps. So we know that things are coming and we'll ask people like, hey, this is about to come up. Where are you going to be at? And then we also track things through HMIS, and we will look, we will drive around. If somebody's not in the right spot where we know them to be, we will kind of drive around. There isn't just this like, oh, they move, fuck it, we're not going to see them anymore. Like we are looking, we are asking, we are looking. Yeah.
Yeah. And sometimes we know other people in the encampment or kind of in the other area, and we can ask, "Hey, have you seen so or so?" And they
Yeah.
can sometimes tell us where they are. But it's a real challenge. I think particularly for me when I'm only here, I move through 5 different geographical teams. So it's like if a patient's not around, it might be weeks before I'm able to kind of come back to them. So it's always really hard when you go and you expect to see an encampment and you find out that it's been swept, and that's like another consequence of encampment sweeps is that then people lose that contact with their street medicine team in many cases. And it's really frustrating and really disheartening, but we do our best to try to maintain that continuity.
Well, thank you.
Yeah, that's awesome to hear that you're going into psychiatry and are interested in street psychiatry.
Yeah.
Any other questions or thoughts, reflections, reactions?
Where's the social worker?
So if there's no more questions, their emails are in the chat. And I will send a follow-up email with like the recording, and like some notes that were taken during the meeting. But yeah, thank you again to you guys for giving this wonderful talk. It was very informational. And thank you everyone who's joining us this evening. And yeah, I think if that's it, if there's no more questions, we can end it here. And thank you again, everyone, for coming.
Yeah, thank you all for your kind attention. Thank you, Divya, for helping coordinate this. Really, yeah, I'm really happy to hear that there's like students, young people, and it's okay if you're not that young too. But folks that are interested in this work, we need
Yeah.
more people doing this.